Honourable Member for Bowman.
Thanks, Deputy Speaker. And in joining the debate on this performance authority, I certainly want to retain the very optimistic view that we have in Australia a top 3 performing health system. And it performs as such for very good reason. We have great people. And never let us forget that health systems perform because of the people in them, not the systems around them. It's important to get both right, but the absolutely necessary and sufficient element in that are the people. The great concern then is the zest and the zeal that was very much expounded by the previous speaker. This Labor zeal to reform is a privilege that is earned, not an automatic right of government. And this government needs to remember in every one of its revolutions, and as each revolution arrives, Deputy Speaker, it is less funded than the previous one. So as these progressively less well-funded revolutions occur, but that zeal to reform and tip upside down and change and poke with the desperate hope that it will be better reminds me of that famous quote, "I came, I saw, I was a little confused, I revolutionised, and not very much changed." The great concern of people on the ground is that bureaucracy, certainly in health, has become this 1,000-layer cake upon which ANPA is effectively the icing, yet another layer in an attempt to keep measuring and monitoring health providers. And I think everyone in this chamber would agree that we're trying to do exactly the opposite in health. We're trying to free up and liberate the great ideas on the ground without compromising, obviously, the very important fiscal requirements of running a health system and containing the cost curve that every Western economy is battling with. We don't have that focus in this legislation. When you look for performance, then let us read the detail and see if the word performance is even defined. It is not. In this legislation, is poor performance even defined? It is not. So the very notion of a health performance authority or of an agency is this hope that with another bureaucracy, as you're running around with that hammer, you hope that just to build one more bureaucracy could make the difference that that health system is yearning for, is probably completely hopeless and utterly futile. Because what we have are highly performing competitive states operating in very, very tight economic circumstances. In many cases, we know, with public services in states around this country, the faster they work, the quicker they go broke. And nothing will change with this legislation. We have tonight, in the great city of Gladstone, Queensland, Deputy Speaker, a top 10 city in my state, no surgical coverage for 60,000 people. If there is an incident, a disaster on the Bruce Highway, if there is some need for urgent surgery, Queensland Health will instruct emergency officials in the hospital to stabilise the patient and then throw them in an ambulance to Rockhampton. Now, there's nothing in this legislation that changes that. And the great fear I have, without appearing carping or negative, is that when Australians look at the health system, they wonder, can I access a GP for my child when I need it? Can I go to hospital and hope to be seen in a reasonable time in an emergency? Can I get that operation without being continually shuffled from a waiting list to a waiting list for a waiting list? And then I suspect if you're a senior, you worry about bed block and the ability to be able to shift from being an inpatient, being able to obviously return to your aged care facility and know that there are provisions available for that. Well, these are the 4 prisms through which we need to examine any reform, because that's what Australians demand of us as lawmakers. They're not interested that we've been able to convene an authority and who the person is who will lead it or what the reporting arrangements are. They don't know that the AIHW collects data and the Safety and Quality Council and Healthcare collects data and the COAG Reform Council is collecting data and the ABS is doing the Australian Health Survey. And now what do we have for you, courtesy of the Labor Party? We've got ANPA to collect more data. That's right. Now, do any of these bodies collect data together? Do any of these agencies say, I'm sorry, that was incomplete? Do any of these agencies actually look at each other's data, pull it together and make sure it's reporting off the same platform? Of course not. We've just added in another data collector. Now, please, don't look at me as the guy who doesn't love health data, but it is not the sufficient element to get a functional health system. We're all collecting the data. The problem is it's not being processed, it's not being collected on a level platform, it's not being equally compared between jurisdictions. Will ANPA do that? Alas, no. That's not their brief. Their brief can be closest compared to the CGRIS, the Coordinator General, that FAXIA has created in their own office to oversee Indigenous services in remote areas, the CGRIS. And this individual who works extraordinarily hard visiting communities and writing large reports about how the data is incomplete and how things should be happening but they're not, is utterly powerless. I mean, the Segrist is funded to write these reports upon which nothing is done. I mean, this individual couldn't even employ his own staff. He's meant to be independent of government, providing independent advice. But Faxia employed all his staff. So the same problem that we see in Faxia and this inability to report independently will simply exist in health, where there are effectively data collection agencies, rewards for doing the right thing in hospitals. But what will happen when we take money away from the hospitals not doing things so well? The patients suffer. So I come back to this element of performance. How do you screw down efficiency in a hospital without affecting quality? How do you make a doctor work faster without him jettisoning teaching? There's nothing contained in this legislation to ensure that occurs. So when we're employing public doctors in public hospitals, some of them are slower because they teach. But how is this going to be measured under some of these reporting arrangements? I go no further than outpatients, where this weekend just gone, Queensland Health dictated to the second largest hospital in the state that only 2 outpatient visits will be allowed before that patient has to be returned to their GP for another piece of paper, another referral. Then you can go back and see another 2 outpatient specialists before you are returned back again to your local doctor, hitting up Medicare, sitting in the queue, the social cost of travelling to a GP. Deputy Speaker, that's not integrated care, but that is a direct result of the federal goal to set benchmarks around how often patients can be seen in outpatients and to encourage throughput in outpatients and, obviously, room, which we support for new outpatients. Queensland Health responded as any provider would. Cap the visits to outpatients. So a 50-year-old woman diagnosed with diabetes, late stage, low levels of literacy, brought into PA hospital, referred to that particular hospital, can see the diabetic doctor and can be referred across to the dietitian. But after that, down come the shutters, straight down to the GP, wait in the waiting room and get another referral before you can come back and see the podiatrist or the cardiologist, let alone going back to the diabetic doctor again to report on what's happened. So this is how we know that providers will respond in an exquisitely rationed environment where you don't have the incentives running the right way. This legislation will not free up the consultants and the staff to do innovative and imaginative things, because those who are immediately above them in their bureaucracy are so panicked about having to report data that they don't allow the freedom. We don't reward clinicians for great innovation. There's nothing in this legislation that allows that to happen. I speak on behalf of patients who are looking for an interstate operation. Deputy Speaker, from a smaller state like Tasmania, you will know that not every one of our 8 jurisdictions, while they do an extraordinary job, can do every operation. We're a health system a 20th the size of the United States. So Australia, a great system as it is, health system as it is, can't expect to provide in every one of our 8 jurisdictions every operation known to the health system. At some point there has to be consolidation, not just for breakthrough operations, but for operations that aren't done as frequently anymore, like clipping a large aneurysm in the brain. Most of them are done with an internal platinum coil, but some of them still are so large we have to do open brain surgery. There's so few of them done that in many jurisdictions there's barely one a year. Well, do I have to keep funding a doctor and keeping that doctor trained to do the one operation, or is it more sensible to send that person across to a larger state? Well, what happens? Up comes the walls of bureaucracy. Does anything in this bill fix that problem? For the lady who has a serious vascular disease of the brain, needs operation on the Circle of Willis and waits weeks and weeks and weeks, while hospital systems shuffle responsibility between each other and the respective states refuse to free up operating time. This isn't addressed at all by a performance agency as described in this legislation at all. It will remain. So I want to just temper the optimism from the other side, an almost euphoric optimism that by creating this new body that all things can be fixed in the health system. It's actually much harder than that. The right to reform a health system is a privilege that is earned. It is not an automatic shift to a new revolution because we need another press release. And as I said about our previous Prime Minister, Deputy Speaker, he'd revolutionised everything else, and I said, I promise you, he hasn't fixed the health system, but this ex-Prime Minister, Deputy Speaker, has one more revolution up his sleeve, and that's the revolution of the health system, and sure enough it came along, and it came along just a couple of weeks after the opposition leader announced so insightfully hospital boards for the struggling health systems of New South Wales and Queensland. And what were they? They were effectively administrative and reporting boards to oversee the work of bureaucrats in each one of our hospitals. They provided information to the public, and they also took information directly to bureaucrats and obtained answers. Now, whether you like the idea of hospital boards or not, it was only weeks later that we were sold from this administration the notion of equally local boards that happen to cover regions as large as 9 major hospitals. And to hear the previous speaker saying that decisions sometimes are better made locally is one of the great understatements from this current government. Because, Deputy Speaker, there is nothing local about the Medicare locals. The word Medicare is only in there at the insistence of the staffers of the previous Prime Minister. So we're left with this curious term Medicare locals that actually is an amalgamation of a number of divisions. So if the previous speaker really loves local health decision making, what was wrong with basing it on divisions? What was wrong with working with our existing structures? They were completely adequate for that role. But instead we're left with Medicare locals that, wait for it, don't conform to local hospital boundaries. So here are our hospital boundaries, and the Medicare locals run across like this. So patients are in one hospital boundary and a different Medicare local. It should have been quite easy to fix, Deputy Speaker. And it wouldn't have been that hard also to align those boundaries with ambulance boundaries, so that the ambulance takes you to the hospital where you live and where they work. It wasn't hard to do that either. It wasn't hard to align some of those boundaries with local boundaries of interest, like local government areas, because they run the emergency responses in most states I've been to. But of course what happens is they don't do it very often, they often don't have the capacity, and then they find themselves with a conflict of interest because the large hospital is located in a different local government area to those where the people are affected, and Queensland floods were such a great example. Toowoomba was mostly focused on Toowoomba needs, and of course all the other local government jurisdictions had neither the capacity to respond to the floods nor the ambulance services to go out and reach the Australians that needed it most. So another simple solution which has been completely passed up. Deputy Speaker, I've spoken about the surgeons, I've spoken about the patients that rely on services. I've talked about how outpatients effectively won't change, and if it does, we could compromise teaching. We've talked about waiting for a waiting list by being on a waiting list for the waiting list and by being constantly passed over. The only way off a state government waiting list in many cases, Deputy Speaker, regrettably, is to get sicker until you need it urgently, is to give up waiting and take out private health cover, or for many, tragically, to pass away. And that is not the health system that we signed up for. We as a nation signed up for a responsive system that actually rewarded innovation. Easy to say, but not fixed with this notion of a performance authority. The one glimmer of optimism, and I've been asked for optimism from the other side and I'll give it to you, the glimmer of optimism is that there are great people on the ground who will decipher the Health Minister's press release. It's one page, Deputy Speaker, and they're trying to work out what is she going on about? What could this mean for my job? The one thing about reform, Deputy Speaker, is that when you threaten everyone with their jobs in reform, the first thing you focus on is keeping your job. And most of the health professionals right now are seriously wondering, where will my program be when Medicare locals evolve? What is the relationship with state community health, which in many major cases and jurisdictions have refused to merge until 2015 or later? When people are frightened like that, you don't get the innovation you need. You get perverse reactions and people operating often to work out a way to save their job. We don't have any undertaking yet on whether there will be a state-based role for divisions, and it seems almost inconceivable that this large number of Medicare locals can operate completely independently and find the capacity they need to do training and operate as political bodies as well as funding bodies, and then also to be reporting directly to Canberra. To do so without some form of state collaboration means that Medicare locals can't talk to state governments, because that's been wiped out. So there's a number of concerns that I have about this legislation that have not been addressed. Australians will look back on us and judge us harshly. They'll look at the health system 5 years from now and they'll judge the administration today for the decisions they made. And I remind them, without giving gratuitous advice, that they will look at waiting lists, they will look at the availability of a hospital doctor. They won't appreciate seeing public hospitals secretly bulk billing patients, undercutting GPs, suspending continuity of care, and most importantly undermining deputised medical services. The very after-hours care that ensures that people who get sick at night have their medical records transferred back to GPs. Well, that's all wiped out as well. This is a government that doesn't understand after-hours care or how to deliver it, and it can all be solved, Deputy Speaker, with a hotline. well, they will learn it is not that simple. Healthcare is extraordinarily complex. You tamper with it with great care and caution, and you make sure you have the best minds on your side when you do it.